Thank you. Would you mind? Good morning, everyone. This is Selena Lin with AMIQT. Today, I'm going to talk about the Neurological Association with Coronavirus Disease 2019. A novel coronavirus SARS-CoV-2 was first reported in Wuhan, China, December 2019. Since then, it spread rapidly around the world during the past 15 months. This virus is encoded by an unsegmented single-strand RNA ranging from 26 to 32 kilobytes. This virus inserts its RNA into the cell and hijacks the cellular machinery to produce new viruses. Coronavirus is named after its spike-like structure, creating an effect of coronal, which is the Latin word for coron. In fact, current vaccine gives instruction to ourselves to make a similar harmless piece of spike protein structure that activates the immune response against the virus. One of the most common and important presentation of coronavirus disease is respiratory syndrome, such as COVID pneumonia. We can see that chest CT shows a severe COVID pneumonitis with patchy ground glass infiltration on bilateral lungs. By far, we've also already had coronavirus already resulted in over 100 million confirmed cases and more than 2 million deaths. As the number of COVID cases rises, reports of neurological features are increasing too, as conditions like stroke and encephalopathies can lead to lifelong disability. Here is a SWI imaging demonstrating cerebral microbleeds in temporal, frontal, parietal lobes of the patient with COVID pneumonia. So the possibility coronavirus route of infection into the brain include infected monocytes in the bloodstream, bringing the virus to the brain with the viral-induced disruption of tight junction on the endothelium cell, which leads to a blood-brain barrier dysfunction. And in this way, virus invades the brain. And coronavirus can also directly invade the nervous system via olfactory epithelium. The virus can also go through a retrograde axonal transport spreading from respiratory and intestinal tract into the brain via vagal nerve. Furthermore, immunoresponse against the coronavirus infection can cause secondary damage to CNS and PNS as a result from secondary hyperinflammation and cytokine storm. The mechanism of neurodegeneration upon coronavirus infection may involve brain hypoxia due to inadequate blood supply or cerebrovascular accident. Blood-brain barrier disruptions also seen in the disease. So immunocells can infiltrate, migrate to the brain and release pro-inflammatory cytokine, induce release cytokines like TNF, alpha, interleukin-6 that cause excitotoxicity and mediate axonal damage. In this way, cause neurodegenerative damage. Among neurological manifestation of COVID-19, the most common one is loss of sense of smell and taste, and it occurs in up to 85% of patients. The other neurological symptoms occurs in about 30% of COVID patients, with up to 45% patients with severe respiratory symptoms can develop neurological complications. Headache is one of the quite non-specific common neurological symptom in COVID, but it's also presented in a lot of other virus infection. And it also has been reported that 31% of COVID patients has altered mental status, including 13% with encephalopathy, among which 6% with severe encephalitis. Stroke has been reported in 2 to 6% of hospitalized patients, and 62% of patients with automental stata had at least one cerebrovascular event, including 46% with ischemic stroke and 7% with intracranial hemorrhage. Muscle injury is not uncommon with raised creatinine kinase. Also, neuropsychological impairments are not uncommon, including psychosis, cognitive impairment, and affective disorders. This graph shows a timeline for positive diagnosis test and the presentation of COVID-19 associated neurological diseases. We can see there's a time interval between the onset of COVID symptoms and the symptoms, the neurological symptoms. And I would like to talk into details about the neurological symptoms in the following slides. So first of all, encephalitis is an inflammation of the brain parenchyma, usually caused by an infection directly or the body's immunoreaction. It mostly starts from the time when the respiratory symptoms starts until 17 days afterwards, typically present with irritability, confusion, reduced consciousness, seizures, and some patients can develop ataxia and eye movement disorder because of an involvement of the cerebellum. CSF can be either normal or show pleocytosis, which means an increase in white blood cell counts. And in this case, it's mostly lymphocytic. But it can also be normal. Brain image can be normal too, but some patients can show the temporal lobe changes. Like the left image showed hyperintensity along the wall of inferior right lateral ventricle, and the right image showed the MRI flare showing a intense change in the right temporal lobe and the hippocampus. And there might be a little bit hippocampal atrophy as well. So it's quite typical as a virus encephalitis. The management is mainly supportive, non-specific, including anti-seizure, anti-epileptic medicine, antiviral, antibiotics. There were some patients who responded to high-dose steroids. Oh, is that okay? Sorry.
Yeah. We have a charger here.
Okay, so there are some patients reacted to the high-dose steroids, but there hasn't been a clinical trial to validate this treatment. Other encephalopathies without evidence of brain parenchyma inflammation can result from hypoxia, toxin, drug, metabolism derangement during the courses of coronavirus infection. Symptoms developed hours to days, including dizziness, impaired deduction of executive variable. This is a T2 flare MRI showing hyperintensity with the bilateral medial temporal lobe, and here shows a white matter hyperintensity on T2 flare. The management is mainly non-specific and supportive. Adams syndrome is acute disseminated encephalomyelitis, is a condition of multiple demyelination, which typically occurs weeks after an infection. Generally, the presentation include dysphagia, dysuria, encephalopathy, seizure, reduced consciousness, and the spinal myelitis can cause acute flaccid paralysis with urinary incontinence, hyporeflexia, and sensory loss. CSF is normal. MRI flare can show increased number of demyelination lesions. Here, this one showed the supra and infratentorial lesions. And this is another MRI showing spinal MRI showing longitudinal extensive transverse myelitis with necrotizing areas. treatment include IVIG or steroids or immunotherapy, but it should be used with caution, especially when the virus is detected in CSF, because such treatment might diminish patients' immune responses to the virus. Guillain-Barré syndrome is an acute polyradiculopathy caused by post-infectious autoimmune reaction. It starts on day 5 to day 10 after onset of viral illness, with rapid progression, symmetric limb weakness, reflexia, sensory symptoms, and it can also present as Miller-Fisher variants with eye symptoms. So it can be quite a typical Guillain-Barré syndrome in COVID. CSF shows albumin cytological dissociation, meaning elevated CSF protein without pleocytosis. Anti-GD1B is an antibody that can be found in a proportion of patients with Guillain-Barré syndrome and Miller-Fisher syndrome. This patient can be treated with IVIG ventilatory support if diaphragm is involved. Furthermore, muscle injury is not uncommon and can be seen in about 11% of patients with raised creatinine kinase level. Some case of rhabdomyolysis is also reported in COVID patients. Loss of sense of smell and taste that have emerged as the most common neurological symptoms, either with other features or in isolation, suggesting that they can be used as a diagnostic marker, but to be aware that they can also present in other virus infection like flu. Furthermore, the pro-inflammatory hypercoagulative status of COVID-19 patient increase the risk of the cerebrovascular events, especially in those patients with comorbidities such as hypertension, diabetes, hyperlipidemia, and vascular disease. Stroke usually starts at a median of 10 days after the onset of respiratory illness associated with multiple infarct, arterial thrombosis, limb ischemia, deep vein thrombosis, pulmonary embolism. In the blood, we see raised D-dimer concentration, which is inconsistent with the inflammatory coagulopathy state of the critical illness. Imaging can show either infarct or hemorrhage, and this one is a head CT showing ischemic lesion involving left occipital lobe and the right frontal precentral gyrus that happened after an acute stroke of a COVID patient. And this lower image showed a series of MRI demonstrating a cerebral infarct in the left basal ganglia, cortical territory of the left middle cerebral artery, and hemorrhage transformation in the basal ganglia, as you can see from here, indicated by the arrows. So immediate anticoagulation with low molecular weight heparin has been recommended for patients with COVID to reduce the risk of thrombotic disease, but it must be balanced against the risk of intracranial hemorrhage, including hemorrhagical transformation from an acute infarct. We are also interested in post-COVID small fiber neuropathy. And so far, there's only one case reporting a small fiber neuropathy caused by post-treatment Lyme disease syndrome, but it was exacerbated by COVID, possibly due to autoimmune reaction. Patient present with severe leg pain, with burning sensation at feet and hands, twitching, vibration sensation at her face, blurred vision, headache, and urinary incontinence. And this all occurred 3 weeks after the onset of viral illness. Skin biopsy confirmed reduced epidermal nerve fiber density, while pseudomotor testing confirmed reduced the electrochemical skin conductance at feet and hands. 3 months of IVIG treatment successfully resolved the leg pain, brain fog, urinary problem, and blurry vision of the patient. At last, I want to talk a little bit about the vulnerability of pre-existing neurological condition in the background of COVID pandemic. Parkinson patients, surprisingly, their COVID risk, morbidity and mortality are not much higher than the general population, but they do have worsening motor and non-motor symptoms when they contract COVID coronavirus. Similar to the case with Spanish flu, COVID infection might trigger neurodegeneration decades down the road by accelerating aging in brain tissue, which awaits to be confirmed through long-term follow-up studies. Regarding patients with Alzheimer's disease, dementia in advanced stage of disease might represent a risk factor for mortality in COVID patients. Also, worsening of clinical spectrum, especially neuropsychological symptoms, have been seen in AD patients who contracted COVID. In multiple sclerosis patients, progressive course of multiple sclerosis, male sex, and comorbidity are risk factors for severe COVID outcomes. And there is a higher chance for MS patients to develop neuropsychiatric symptoms due to COVID pandemic, and that's not surprising. There are some interesting concepts about patients who are taking immunosuppressant. They actually have a lower chance to develop or be suffering from the effect of cytokine storm, and so awaits for a further study to confirm. So in conclusion, given existing knowledge of coronavirus, the wide range of CNS and TNS association with COVID-19 is not surprising. However, neurological disease is likely to be seen increasingly in those patients with fewer or no typical feature of COVID. So we need to do more case control study to figure out if SARS-CoV-2 is the cause of a neurological condition or it's just a coincidence. So we need to do more study about that. So the continued pandemic will likely result in a bigger number of patients with neurological conditions to be reported. And the neurological complications such as encephalitis and stroke can cause lifelong disability and potential higher cost of health care. Therefore, we need more careful clinical diagnostic and epidemiology study to figure out the neurological association with COVID and the burden it might bring us. And that's all for my talk. Thanks, Dr. Burnett. Thanks, Dr. Stan and Dr. Naka for the wonderful opportunity for me to be here doing the neurological rotation. Thanks to all my colleagues here, all the medical student doctor I met here during the 3 weeks, and thanks to all the patients. They're the motivation for me to work hard and practicing medicine every day. Thank you all for your patience, and let me know if there's any questions. Thank you very much.
Thank you very, very much.